Okay, today we're presenting a case for D-Team conference. We have patient SP. She's a 66-year-old female who presented to the ER with about a day's worth of abdominal pain and some nausea, as well as dark brown emesis. Of note in her history, about a couple weeks prior, she had presented to the ER with some orthostasis and was found to have symptomatic anemia. She was admitted to medicine at that time, given 2 units of RBCs that she responded well to, and didn't get much more of a workup than that, but had a negative fecal occult blood test at the time. She notes that when she comes back to the ER this time that she's had a decreased appetite and kind of a dull abdominal ache since the last time she was in the hospital, and she does she's due for a colonoscopy, but she had a normal one about 10 years ago. Also of note, she notes a 20-pound weight loss over the last month. She attributes this to a diabetes medication, but that is something new for her. So her history is notable only for prediabetes, hypertension, anemia, pretty minimal surgical history, just a C-section and tubal. She takes metformin and ramipril for her medical conditions. Interestingly enough, in her family, her brother had pancreatic cancer, and then otherwise an unremarkable social history. So she presents afebrile and hemodynamically normal. On exam, the only thing remarkable is that she has a large, mobile, but non-tender mass in her right upper quadrant that's about 10 centimeters large. But her abdominal exam isn't significant for a Murphy sign or any sort of ascites or anything like that. Her labs are relatively normal. She's a bit anemic, but not to the point of needing transfusion like last time. Has a completely normal comprehensive metabolic panel and a mildly elevated lipase. Then they proceed to a CT scanner and get a CT abdomen pelvis with IV contrast. And as you can see right there, she's got quite a large lesion that's just over, it's about 10 by 9 by 12 centimeters. A little hard to show you the full extent of it over PowerPoint, but you can kind of see from this, the stomach's mildly distended. This very large mass appears to be occurring right in the peripancreatic area, right along the 3rd and 4th part of the duodenum. And it's fully obstructing at D3 and D4. There's no gross lymphadenopathy that's apparent, and then also of note, no studying of the liver, no peritoneal masses as far as we can tell, and there's pretty significant compression of the SMV and then partially compressing the IVC as well. And then everything else is pushed forward with the mesentery and the main portal and IMV displaced anteriorly. But just from what you can tell here, it's a pretty large heterogeneous mass. It's relatively well encapsulated for its size and creating quite a bit of mass effect. So at this point, she's admitted, or actually, sorry, if we can go to the next slide. So quite a large differential at this point. It looks like it's around the pancreatic head, either arising from the duodenum or pancreas, and pretty large differential of what this could be at this time. Due to its size and it's how well encapsulated it is, it looks like it could likely be a GIST, but you always have to worry about it being an adenocarcinoma as well. And then rare things like the neuroendocrine carcinoma or case reportable, a Brunner's gland hamartoma being something that large and obstructing. And then if it's arising from the pancreas, more commonly being an adeno or with its heterogeneous appearance, could also be something like a cystadenoma or cystadenocarcinoma, and again, a neuroendocrine carcinoma. And then kind of where...
Pause there for a second, Lexi. So Beth, looking at that image, What would your first three on your differential be? I mean, we've given you 12 or 15, but what would your first three be?
So looking at kind of the location of that and hearing that it's in the duodenum and hearing that it's well encapsulated, number one on my differential would be a GIST. And then we also mentioned adenocarcinoma also being something common.
What kind of
Well, I
adenocarcinoma?
wouldn't say common, but what was that, sir?
What kind of adenocarcinoma? Pancreatic adenocarcinoma?
Small bowel adenocarcinoma.
That's not pretty common. I mean,
Yeah, I agree.
the thing on this slide that has you thinking it's probably, and I agree with you, and that's what everybody else agreed with you. The thing on this slide that makes you think it's probably either GI stromal tumor or small bowel adenocarcinoma is this bit right here. You see the mucosa lining is nice and enhancing right here. And then
Okay.
right here it goes away into this mass that seems to be exophytic and pushing stuff away. What we can't show you because we don't have impacts is this thing is displacing the pancreas. It doesn't look like it's actually arising from the pancreas. It looks like it's pushing the pancreas away. Again, suggesting it's a duodenal issue. And the top two duodenal things would be small bowel cancer, like you're saying, or GI stromal tumor. So that's exactly right. Okay, Lexi, go on.
Okay. And then just to round out this differential, there's a lot of very rare things. It could be a sarcoma of many different varieties. The most common of those sarcomas, and somewhere like the duodenum would be a leiomyoma or leiomyosarcoma. And then you kind of get rarer and rarer as you go down the list, to include something like a Ewing's sarcoma of the small bowel as well. So in the ER, they place an NG tube and they get back output. She ends up being admitted to the medicine service with a consult for GI who's planning to take her the next day for an EGD with endoscopic ultrasound and a needle biopsy. Surgical oncology was we got on board the next day and completed her metastatic workup with a CT chest. It was remarkable for a right lower lobe nodule as well, but not diffuse metastatic disease or anything. So she's taken that day for an EGD, an EUS. You'll see on this next slide that there's quite a large fungating mass that's very apparent in the third part of the duodenum. It's just distal to the ampulla. So yes, as you can see, not hard to miss. It involves greater than 50% of the circumference of the duodenum. And then this dark coloration is consistent with chronic inflammation and then also likely necrosis from the mass effect of the tumor pressing against the mucosa of the small bowel, which is also probably the etiology of her upper GI bleeding.
Okay, pause there again. So Beth, does this change your differential at all?
I think I have evidence at this point that's in the duodenum, and I think that hearing it's a necrotic bleeding obstructing mass is consistent with what we discussed.
So you're gonna say more GIST or more small bowel cancer? I could not.
From what I read, both of them can cause those types of things.
Okay. All right, let's move ahead. Go ahead, Lexi.
Okay, so also they look at the mass with the EUS kind of through the stomach and through different parts of the duodenum. As you can see, it's very large, it's irregular and hypoechoic, as well as solid. So not kind of brings your cystic masses on that differential down a little bit. But it's pretty clear, especially on the EUS, that it's not coming from the pancreas. The pancreas is actually pretty small and compressed and displaced, as Dr. Krell said. And then you can also, they're not pictured here, but you can visualize the SMV, but it's adjacent to the mass, but very compressed. They take a look at the celiac axis and note that that appears normal and that there's no evidence of large lymphadenopathy either. So they take some biopsies at this time, and they, on their very preliminary examination of that, it looks like most consistent with a GI stromal tumor, but not consistent necessarily with an adenocarcinoma based off of that initial path on the first day.
So send us, what on the fine needle aspiration will tell us it's a GI stromal tumor? What markers?
So it's a KIT mutation and CD117.
Yeah, CD117, which is KIT. And if KIT is equivocal, there's another marker that you should be aware of.
Not sure of that one.
And one's called DOG1. You know what DOG1 is for?
No.
Stands for diagnosis of GIST, to keep it simple for the surgeons.
I like it.
Okay. So in this one, the fine needle aspiration, the cytology is stained weekly for KIT. So going down that road, Beth, if it's staining weekly for KIT, is it a GIST?
I think that gives us evidence that it is.
Yeah. Are there GISTs that do not have c-KIT mutations?
I would bet yes.
Yeah, it's pretty rare. It's about 5 to 10% of GI stromal tumors do not have c-KIT mutation. And they have mutations in other tyrosine kinase receptors. And there's this so-called wild type thing where they don't have any discernible mutation until now that we've done more next generation sequencing. We found out they actually have something called like a succinyl dehydrogenase mutation associated with it. And those are people that tend to have GISTs that run in families. So right now we have a c-KIT weekly staining tumor that seems to be duodenal and compressing other things. What is the leading differential?
A duodenal GI stromal tumor.
Yeah, good. We're not overthinking it. I like it. Okay, Lexi, what's there? What's next?
All right, so so at this point, as we've already said, leading differential is GIST, consistent with our imaging and with our initial stain. So just very briefly covering what basic characteristics of GIST are. Typically, they actually present as an incidental finding that you might see on a scan for another reason or a scope for another reason. But when they are symptomatic, that they can cause pain, nausea, vomiting, and then very rarely they present with something like GI blood loss, like our patient has. As we kind of alluded to already, associated familial syndromes include neurofibromatosis 1, Carney-Stratakis syndrome, which is one of those germline succinate dehydrogenase mutations, or VHL. So the important prognostic factors to keep in mind for GIST is where they're originating from, usually divided between gastric or non-gastric, and they can occur anywhere within the GI tract, and that what their mitotic rate is, high grade or low grade, defined by less than or equal to 5, high power fields are greater than 5, whether they're CD117 or c-KIT positive, and that helps determine treatment that they can receive neoadjuvantly or adjuvantly, and then whether their margins are positive when they're surgically resected.
Sure. Let's pause there. So this is a duodenal, we're presuming a duodenal GI stromal tumor. Connor, or sorry, Chick, can you tell us the difference in the operative approach for a duodenal GI stromal tumor as opposed to, say, a pancreatic or a small bowel adenocarcinoma?
Sorry, you said for a duodenal GIST versus.
Yeah.
Oh, I'm sorry, I understand now. Yeah, so the
between...
biggest difference is you don't. This is not an oncologic resection as you would for adenocarcinoma as far as lymph node sampling. So for duodenal GIST, the goal is to get grossly negative margins. And so if it's a distal duodenal GIST, you can do just a segmental resection and a DJ. If it's more proximal, like near the ampulla, you can, especially if it's anti-mesenteric, you can just do like a lateral duodenectomy and then duodenostomy to reconstruct.
And that's the Kaihara procedure. And that's exactly right. So the big thing when planning these things is the lymph nodes, like you just said. With Whipple's for adenocarcinoma, something where we want to get nodal staging, we also want to make sure we get all these nodes. But with GI stromal tumors, the nodes are less of an issue. Now for this one is compressing the duodenal head, or sorry, this one's compressing the pancreatic head, and it's all up in the porta. Do you think you could take this thing out without a Whipple?
Sorry, I was muted. Probably not.
Yeah. So sometimes we have to do a Whipple for these things too. So that's what that's gonna, I think Lexi's gonna talk about that in a little bit and how we're gonna plan for that. Is that right, Lexi?
Yes, sir.
Okay. So staging out. Big things on just GI stromal tumors, like in my clinic, you'll hear is 3 main things: origin, so stomach versus not, size, and mitotic rate. Those 3 things give you the risk stratification you need to see whether these people need systemic in addition to surgery. There are multiple trials of Gleevec. We're not going to go too much into it right now. But the big thing to figure out is whether this patient's at high risk of relapse. So Cindus, with what you know about GIST, this is not gastric. This is a non-gastric GIST that's over 10 centimeters, and it looks really ugly. Is this someone that would get imatinib? I can feel Cinda saying yes. So the answer to that is yes. Someone, if it's a GI stromal tumor, would get imatinib at any rate. When we've studied this in clinical trials, this particular patient would have fit in all the imatinib trial profiles, and so they would have gotten it regardless. So, okay, Alexi, so what are our surgical options?
All right, so Connor already briefly alluded to some of these, but you can go to the most extreme, which is the Whipple procedure, versus there are also other procedures described when the pancreas is completely uninvolved in your pathology. You can do something called a pancreas preserving total duodenectomy, where you basically divide or take out the entire duodenum and reattach your ampulla to a loop of jejunum. Or depending on the location of your tumor and its proximity to the ampulla, you can do, if it's not close at all, you can do a limited partial duodenectomy and then do some version of an anastomosis of your duodenum to your jejunum. And then if that is a little bit close to your ampulla, you can add a papilloplasty or a pancreatic stent to ensure adequate drainage.
I know Hada's here because she's texting me. So Hada, how do we, can you talk about a pancreas preserving duodenectomy procedure? How did we do that the last few times?
You mean just like what? Okay, so we started with like the first time it took a little bit more time because we didn't do a full Cattell brash, but once we converted to that, we got better exposure. You do a full coker, mobilize the duodenum, and then sort of get your distal resection point. And then take that and then take down the ligament and trites and bring the duo up and over to the through the ligament and trites, being very careful because there's a bunch of really small blood vessels there between D3 and the pancreas around that region, and then get your proximal resection line. We oversewed that and then did duodenojejunectomy.
Yeah, tell them how we do the duodenojejunectomy, because it's something that, well, we rarely do it in general, but we particularly rarely do it here unless you're on my service in October.
You mean like a side? So we did a side-to-side hand sewn on the lateral aspect of the duo.
Yeah. So you end up resecting more jejunum than you need to, just so you can mobilize it, right? So we took a lot
That was the
more
thing that I
proximal J,
wasn't
and then
expecting.
we route it up through a retrocolic window, like a RULM, although it's not really a RULM in this case. you sew, and then you sew it to the side of the duodenum. And what was the key in both of those cases for us to figure out whether we could actually do the duodenal sleeve resection?
Knowing the location of the ampulla, you mean?
Yeah, exactly.
Or
Yes, yeah, we
okay.
we checked the ampulla like as many times as we could to make sure we weren't buggering that up. So this is gonna be a chief level. So Kai, since you're on a roll, with this particular map, it's taking out or it's splaying out the superior mesenteric vein, and we have collateralization. It's crossing over the midline and it's compressing the renal vein. And if you think this is something that we can safely get out with a duodenal sleeve resection?
No, well, isn't it in D2 as well? Like, isn't it right around the ampulla?
Yeah, it's really hard to tell because it's distorting everything so much. Based on what's coming out of our NG tube, I don't think it's at the ampulla. One, because on scan you can see that D2 itself is really dilated.
hmm
So I think it's a potential thing, but more than that, like it's because it's pushing up everything and it's taking out the superior mesenteric vein. Is this something that
Yeah.
would you safely get at that with any of the standard options?
No, I
Yeah,
don't
and
think
if
so.
it was a Whipple, for example, what kind of a Whipple would we need to do? What else would we need to do in addition to a Whipple if this thing's taking out the superior mesenteric vein?
If it's taking out the SMV, but you have collaterals, but you don't know if you're going to take down those collaterals during the dissection, you most likely will. Don't you have to just reestablish venous flow? Is that kind of what you're getting at?
Yeah. So I'm getting at this would be most likely Whipple with vein resection
Yeah.
of the main SMV. And have you heard of anybody doing that for a GI stromal tumor?
No, you wouldn't even really do that. Well, I guess you could do that for adeno, but
Yeah, we do it for adeno sometimes if that's the only thing. But the reason you haven't heard of it for GI stromal tumor is because almost nobody would do that. So
sorry,
in
when you say taking out the SMV, is it just compressing it or is it like actually invading it? Because I thought these were more like pushy tumors rather than invading tumors.
this case, it's going to be really hard to tell. And I can tell you as Lexi goes on, we couldn't tell. So my suspicion is it was just really pushing it and splaying it out and not invading it. But you can't assume that in the operating room. So when you're in the
Right.
operating room, if it looks like it's taking it out, you must assume that it is invading it. So you take that so you can get your margin clearance. So that's big time stuff. Okay, Lexi, go ahead.
And then other options with this obstructing duodenal tumor is just to establish feeding access with doing a gastrojejunostomy, and then laparoscopy to make sure you don't have any other metastatic spread you weren't able to see on scan. So we've talked, I'm sorry.
I was saying, so the bottom two on the left side of the screen, the bottom two images are exactly what Kai was describing when we did our sleeve duodenectomies for the D3 gists. So you take the tumor out on the far bottom left side. You take the tumor out by separating that D3 from the inferior border of the pancreas, and you can do that. There's a lot of these little tiny perforating vessels that you have to take slowly, but then you just have this loop of the duodenum, just like any other loop of small intestine, staple, and then you route it up and sew it side to side. It never looks as pretty as that picture to the right of it, that D picture. It never looks that pretty, but over time, these patients dilate up that anastomosis and they live pretty normal lives. So the two guys that we did that to, I saw them in January, February, and then they were like totally back to normal. So even though it looks weird like that, they do just fine.
Yeah, so I think we've already talked through most of these at this point, but it really depends on, as Kai and Connor have already talked about, where in the duodenum the tumor is and how large it is. And because if it is a GIST, you just need grossly negative margins, but not centimeters or anything like that. You can't just wedge it out if it's in a amenable spot for that. But otherwise, if it's more proximal to the ampulla, you're looking at something more like a distal gastrectomy with a Billroth 2 reconstruction versus if it's more distal, doing the partial duodenectomy with a side-to-side anastomosis. I feel like we've already kind of talked about the rest of it. So at this point, she's going to the OR and we need to decide whether we're going to perform a Whipple or not. So reasons why they were considering doing it was because we definitively would get the tumor out theoretically, as long as that margin, especially around the SMV, could be safely resected. And then this mass, while we think it is distal to the ampulla, it is very, very close and likely wouldn't have a very safe reconstruction option, especially at the current state of the tumor. So she would need a full Whippled due to its proximity. And then we technically don't have a final pathologic diagnosis at this point, so ideally we would get lymph nodes to go with our specimen, which you would get with the Whipple and not so much with everything else. But reasons not to do it. This patient's lost 20 pounds in the last month. It's a very morbid, one of the most involved surgeries we could do, and this patient doesn't have great nutrition. We had, like I said before, we don't know what its pathology is at this point. So whether this truly is the best operation for her or not, we don't know if we're going to be able to cleanly get all of the margins, and likely have to do a vein resection with the SMV involved. And then also, especially if it's something like a GIST and it could respond to something like imatinib, we could downstage the tumor and then potentially could need a lesser operation than a Whipple down the line if it responded well to neoadjuvant chemotherapy. So, sorry.
Let's pause for a sec again, because that's a really good summary of the relevant issues. Peace, you there? Not getting Peace, or is she still muted? Christina Lee, you're with us. We're gonna go into some principles questions. So if we're talking about a patient with a GI stromal tumor that we would give imatinib to, is there any difference in whether we give it before surgery or after surgery in terms of their cancer specific survival?
Well, so I know for management you want gross resection and then adjuvant. I didn't read about neoadjuvant other than for like unresectable or metastatic disease.
Yeah, okay. That's right. So from a conceptual standpoint, when we say neoadjuvant, the reason we call it neoadjuvant instead of pre-op chemotherapy is because we think from a cancer standpoint it behaves somewhat similarly. So what do you know about adjuvant imatinib? How does that influence survival from GI stromal tumor?
So the study I read, they said initially imatinib did increase disease recurrent free survival, but not overall survival. Is that right?
Somewhat, yeah. So in the initial trials, it decreases patients' risk of recurrence by about 10 to 20%, which was huge. And we don't need to go in the history of it. And then we learned as we gave patients longer and longer durations of imatinib, so rather than 1 year, we gave them 3 years. That's when we started seeing an overall survival signal, meaning that patients that were treated with imatinib for 3 years died less often from GI stromal tumor than patients that got it less than 3 years. So now we're starting to extend it out to 5 years or even longer. And the thought in the community is there anybody in whom we should not just treat forever with imatinib? So the neoadjuvant, we think it behaves from a cancer standpoint about the same way. So why would we give neoadjuvant? Why would we give chemotherapy first, rather if it does the same thing as far as the cancer goes? Lexi mentioned downstaging. What does that say to you? What does it really mean to you when you hear the word downstaging?
Like it shrinks the size of the tumor so that it's not encroaching so much on the surrounding structures.
Yeah, exactly. So when we talk about, kind of the principles of adjuvant chemotherapy after surgery, you got to know a few things. One is the patient's risk of recurrence, and the risk reduction with the therapy itself, the side effects of the therapy, and the salvage for the therapy, right? So with the neoadjuvant, that actually changes around a little bit. Not only do we need to know the likelihood that this treatment will do what we want it to do and its side effects, we also factor in whether it's going to change our operation. So right now we're looking at a Whipple, or a Whipple with a vein resection, as our treatment. What is the chance and maybe you don't know this, but what is the chance, and we'll kick it up to Chick. What is the chance that the GI stromal tumor will respond to upfront imatinib with either a partial or a complete response?
I don't recall any numbers, but my general sense is that they tend to respond very well.
Yeah, and what does very well mean to you?
So a tumor with this size, I would expect that it would at least shrink to a significant degree. I don't know.
Partial response by RECIST criteria. Are you familiar with the RECIST criteria? It's called the response evaluation something in solid tumors.
Yes, sir.
Yeah. So what qualifies as a partial response in RECIST?
So a reduction in volume of at least 30%.
Exactly. And so when they looked at the trials of people with metastatic or locally unresectable, about 70%, 60 to 70% had at least a partial response. So we're seeing tumor shrinkage of some degree, at least 30% in 2/3 of our patients, give or take. And then, do you know what it looks like on scan? So this GIST, when it looks ugly first like that, and then after you start treating them with like 6 months of imatinib, you know what it tends to look like afterward?
I don't.
It tends to look like this, like kind of thick cystic thing, like a thick rinded, almost like an abscess, or like a fluid collection with a really thick wall. So one of the other benefits of the upfront imatinib is that it kind of changes the nature of it, makes it a little bit more of a defined capsule, a little less difficult to spill, or a little less likely to spill tumor while you're taking it out. So that's one of the other things of it. So with the neoadjuvant, not just all those things, we also think about how it's going to change your operation. And in this case, for GI stromal tumors, particularly ones in this location, an upfront imatinib approach is very appealing. Okay, so we took on the operation, and so long story short, we thought that Whipple was probably too morbid, not worth it. So we wanted to do something, what is the least invasive thing we can do to get this patient where they need to go with a bleeding, obstructing tumor? Who's around that can answer that? So we're not going to Whipple, but what can we do? Wow. Okay, cool. GJ, we're gonna do a GJ. Good. All right. Alexi.
Okay, so we take her to the operating room. We see this large tumor, but thankfully, as expected, no peritoneal disease and no malignant ascites or anything like that. So we do the least morbid thing and do a robotic-assisted gastrojejunostomy. And the idea is to really get this patient's nutritional intake up and do the least morbid operation while we get her to chemotherapy. So her GJ was performed in a Billroth 2 configuration, meaning we brought up a loop of jejunum about 25 centimeters distal to the ligament of Treitz. And in this case, they did a posterior GJ, so entered the lesser sac along the greater serve and posteriorly fixed the jejunal limb with Vicryl, and then stapled it on and imbricated over it with more Vicryl as well. So in addition, while they were there, they had anesthesia place a Dobhoff tube and were able to directly visualize placing the Dobhoff tube down into the efferent limb for feeding access while they waited for the anastomosis' swelling to go down and for her to be able to eat on her own in the future. So then we kind of got a curveball, and her final pathology came back, and instead of actually having a GIST, her final pathology came back consistent with Ewing sarcoma, which, if you remember on that differential, was way down at the bottom of the many different types of masses it could have been. So her path was more consistent with these small round blue cells that you see on the right, and they stained positive for CD99, which is consistent with Ewing's. So Ewing sarcoma, it's named after Dr. James Ewing, who described it after seeing a 14-year-old girl who had a highly malignant bone tumor, and he called it diffuse endothelioma at the time. And that's more consistent with what patients you usually see Ewing sarcoma in, and what we learn in med school is the young pediatric patients who have tumors of their long bones or pelvis. But there's actually a family of tumors and 3 main types that are recognized. The Ewing sarcoma is kind of synonymous with this primitive neuroectodermal tumor, or PNET, and then a peripheral PNET is more the extremity type Ewing sarcomas that you see in the bones, versus extraskeletal Ewing sarcoma, which is what our patient has, and then also this entity called Askin's tumor, which would be a Ewing's at the chest wall. So this is caused by a mutation in the Ewing sarcoma gene, or EWSR1. It's usually a translocation with, usually it's between chromosomes 11 and 22, but that can vary. And then, like we said before, this is this very, very rare tumor. Ewing sarcoma, including everything in that family, only occurs 3 cases in 1 million people, and typically it's in those young patients, and more commonly in males. So on the next slide, what we do know about this rare tumor is that they tend to do much worse prognosis-wise if they're large or greater than 100 cc's, which our tumor definitely is. If metastasis is present at time of diagnosis, which isn't surprising, if it's located more centrally or in the pelvis, and then there's kind of this old truism that Ewing's is much worse in the adult population, and this I guess truism has been kind of challenged in more recent studies, but overall it seems that older patients tend to do a bit worse, and whether that's because the chemotherapy isn't more specific to them versus the pediatric population is kind of part of what is under discussion. But typical regimens, and again, these are more proven in pediatrics, is this VACA regimen versus the IVAD regimen for Ewing's. But ultimately, the principles of Ewing's treatment is to surgically resect it and then treat it with chemotherapy.
Let me clarify that, Lexi. So surgeons rarely see Ewing's tumors anymore, except unless they're the bone classical style Ewing's. We get involved way after they've gotten lots of chemo. So the treatment for Ewing's family tumors in general is chemo, more chemo, and then when you think you're done, some more chemo. And then if they're still alive after all that and they have no progressive disease, then you can take it out. Nice. So yeah, the defining characteristic is the EWSR. That stands for Ewing sarcoma. So again, keeping it simple for surgeons. And that is why in this particular case, doing a Whipple would have been the exact worst thing to do. We didn't know about this till after the fact. So I was really glad when we found out that pathology result came back, because a Whipple, while it may have cleared her out of her disease, it really would have gotten in the way of her getting the chemotherapies, which is what she really needs. So, so there's that. Moving on.
So back to our patient after the OR. So she was been doing well. She's passing flatus, tolerating her tube feeds, ambulating. She does is requiring blood transfusion intermittently, and then most acutely had some hematemesis yesterday, as well as some hypotension that responded to further blood transfusion. So it's clear that her tumor is still bleeding, and she needs some sort of intervention to palliatively stop this while she recovers from her GJ and then hopefully gets moved on to chemotherapy. So talking more about basic principles of how to manage a bleeding GI tumor, there's different modalities that you can use to approach them, whether it's endoscopically with GI, interventional radiology or radiation, and then hopefully this will get her to the further treatment with chemo that she needs.
Yeah, we'll say like there's always the option of surgery, but for Kai out there, would you treat a bleeding duodenal tumor that's that large with surgery?
I wouldn't.
Good.
I mean, that's only if they're bleeding and not responding to transfusions, and you've tried, all the normal stuff, like make sure they're not coagulopathic, maybe potentially embolize something, things like that. But I think that you're just kind of asking for trouble if you can't optimize these patients before surgery.
Yeah, no, I agree. So this is different from like a bleeding duodenal ulcer where like, there's always that 3-corner stitch thing that, you can do. This isn't an ulcer. This is a 10-centimeter tumor that's taking out the pancreas and some other stuff. So the reason why, even though she's bleeding, I'm not jumping to, take her to the operating room for it, is because I can't give her a safe operation to control bleeding. That's not an extended Whipple with a vein resection, and that's a terrible operation for bleeding. Okay, so we do that. So they're going to do some of that. So what I asked Lexi to do in this particular case is to talk about palliative radiation for bleeding, which I don't think a lot of people have much experience with. But this is something that's in our armamentarium, particularly in the cancer patients that have either unresectable disease or are so frail that we would worry about putting them under any kind of procedure to fix bleeding. So Lexi, can you talk a little bit about the external beam radiation?
Yes, so typically these are short courses of high intensity radiation. There's several different regimens out there, but they usually range from 1 to 3 weeks, and something like a regimen of 35 gray and 14 fractions. These are really, the goal of this is to reduce the patient's symptoms. So in some of the studies I looked up, the reduction, so the goal is to reduce tumor bleeding, to reduce their dysphagia or obstructive symptoms, and to reduce pain. And usually these regimens can offer anywhere from 6 to 12 months of symptom relief, usually closer to the 6-month range. But that can be prolonged a bit if you add combination therapy such as 5-fluorouracil for chemosensitization. So it really kind of helps reduce the mass effect as well as reduce the bleeding. And then the other option, which is very, very difficult in this type of tumor, is angiographic embolization. Due to the complex anatomy of this area, it requires super selective embolization, and it can or cannot be successful because you're dealing with such a highly collateralized blood supply at the pancreatic head and duodenum. And then in addition to it just being technically difficult, maybe isn't going to work very well, it's also very high risk. They have extremely high rebleeding rates due to this high collateralization. They're usually, in the series I was reading, the rebleeding rates were usually like 40 to 70%. And then you can also risk ischemic complications such as necrosis in the stomach or intestines. And then if you're embolizing with especially something like particles, you can accidentally embolize something like the liver or the spleen, and there are reports of getting liver abscesses after something like this. So was going to blow up the picture a little bit, but as you can see, you would involve having to cannulate either the celiac axis or the SMA in order to get into the GDA, and then the pancreatico duodenal arcades, which you have both anterior and posteriorly. And you would really, in the series that I was reading, it really kind of depends on that patient and that tumor where you would end up embolizing. They're most commonly they would embolize the GDA. Sometimes they were able to get into the pancreatico-duodenal arcades and do a more selective branch. But then there were even some people they had to completely embolize the left gastric. As you can see in the other angiography pictures, it can be relatively successful. On the left, there's a patient who had metastatic renal cell carcinoma to the duodenum, and they were able to embolize off I think we're looking at a pancreatic adeno right now, and they cannulated the SMA and were able to get into the inferior pancreatico-duodenal arcade and embolize, and they obviously had a pretty good success rate, and that was with particle embolization there. And then the other image on the left was when they went through the celiac axis and then into the GDA and embolized the coils for a metastatic renal cell.
Next.
So as far as next steps for our patient today, at least last I heard, they're planning to go for EGD with intervention to try and stop the bleeding that way first. But if they're unable to be successful, she might have to go see IR. And then really the goal is to get her to stop bleeding and get her nutrition maintained enough that we can get her to chemotherapy in about 6 to 8 weeks after she's healed her new anastomosis. And then depending on her response, she may or may not get surgery, but that, as Dr. Krell was alluding to, very, very far away and very dependent on how she responds to that chemo and how she's doing from a functional status at that point, as it will be a very likely a highly morbid operation still. And then if she ends up not being a surgical candidate, to be able to consider those palliative external beam radiation regimens as well.
And let me, this is a complex thing, and you covered it very well. This is always an evolving situation. She may be dealing with a little bit of afferent limb issues. So the EGD is actually more today to do to relook at the tumor and get some more tissue for some more testing, because they're running out of tissue to do all of their complex Ewing's testing. And it's also to look at her anastomosis and see if they can dilate something up to make it a little bit better, a little bit more better. If she continues to bleed, in this case, what we would do is a combination of IR embolization just to slow down the bleeding, in addition to the palliative EBRT, because we can't get her out of we can't get her on chemo if she continues to bleed. So that's going to have to get addressed while she's here with us. And the other thing is, with these Ewing's tumors, you really want to get them on chemo as fast as you can. So once we get this bleeding and stuff under control, and once we're sure we can get some enteral access, we're probably going to get her lined up with a port and see if she can start some inpatient chemo. Because these are tough. These particular tumors are really tough. And we can't, if she doesn't get through chemo, there's no way we're going to be able to get her through surgery. So, unfortunately, in her case, is going to be kind of a test to resolve. Right. That's at 7:55, so we have like 1 minute for questions and orders of business. Any questions?
I saw Christina asked a question about the exon testing. From my understanding, they do test for it because some people are more responsive to imatinib with certain exon mutations than others. Like exon 13 is more sensitive than exon 9, but it's not, and that's usually part of the typical testing is what I understood.
Yeah, the specific mutation in the c-KIT gene is important towards how much imatinib you can give. There are some that respond to the standard dose, which is 400. Exon 9 mutations tend to be more resistant and require 800 milligrams imatinib, and then some, like exon 17, don't respond at all. However, with the neoadjuvant setting, particularly in these big ugly tumors, instead of doing imatinib alone, we're actually doing combination therapy, or at least we were doing this in New York. We're doing combination with imatinib and then a medication called a MEK inhibitor, which is something that we use predominantly in melanoma, but it also works in patients with GI stromal tumors as like a 1-2 punch, and their response rates are through the roof. They're nearly 100% when you give both of those up front. It's temporary like all of them, but it gives you enough tumor shrinkage to really influence your operation. So if it were a GIST, that's what I would have done, is we would get her to a center that can give both imatinib and MEK inhibitor. But that's a GWAS thing that you definitely don't need to know for your boards. Okay, everybody. Good talk, Lexi. Thanks. I'm going to stop the recording.
Really quick. So for next